Welcome to an interesting topic on how structural racism in America informs fertility disparities for Black couples.
So we'll move on to our last speaker, Dr. Kim Thornton. And Kim's response to her why, her passion. She's passionate about increasing awareness of infertility and access for patients impacted by infertility, and in working to develop strategies to diversify the workforce in the field of REI. So Kim will talk to us about why culturally informed care matters. Dr. Thornton.
So thank you, Dr. Richard Davis and the ASRM for the invitation to speak this evening. I'm going to address the topic of why cultural informed care matters. My disclosures on this slide. It has been well established, and Dr. Bey highlighted this very well, that even after you adjust for multiple variables, there are significant disparities in the quality of healthcare that's received among many racial and ethnic minority groups. Black women are half as likely to present for fertility treatment. They often have a longer duration of infertility. They tend to have a lower utilization of effective fertility treatments. And even in mandated states, are more likely to self-pay for services than non-Black women. Black women have lower clinical pregnancy rates and live birth rates compared to white women in both fresh and frozen ART cycles after you've controlled for BMI and infertility diagnosis. And in states where there are insurance mandates, there's been a demonstration that they oftentimes will discontinue treatment earlier. So this discussion, I want to discuss some of the factors that we need to consider as we work to correct many of the disparities among access. It's well known that each of us are a product of the culture, which is the learned and shared knowledge that specific groups use to generate their behavior and interpret their experiences in the world. And it's also where we acquire the values that inform how we think and interact with others. So this, as providers and as well our patients bring to every patient encounter their own set of values to this encounter. In addition, we all may bring implicit or unconscious biases, and those are the attitudes and or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases are oftentimes favorable, but can also be unfavorable, are activated involuntarily, and oftentimes without our awareness or intentional control. And so it's incumbent upon us to understand that there are unconscious biases that we all bring to encounters, and then recognize how they might impact the care that we deliver. So in terms of what are some of the provider biases, as we've discussed, Black women oftentimes receive later referrals for infertility. So you might ask the question, why is this the case? Well, if you are a provider that believes that a patient may not comply with the rigorous treatment schedules required of fertility treatment, or if you think that the patients may not be able to afford the care, then you may make the decision not to even refer them for fertility care. Therefore, you've deprived them of the opportunity to, one, inform themselves about their infertility and the treatment options are available, and let them make the decision about how they would choose to pursue fertility treatment. Additionally, we all make assumptions around whether we think people either need more children or deserve to be parents. Oftentimes in our counseling of patients, and especially when you think about primary care providers and generalists practicing gynecology, we often have a narrow focus when we're counseling patients on contraception rather than reproductive life planning and family building. So in fact, ACOG has recommended that reproductive life planning be included as part of the of a woman's annual exam, so that we can make sure that we start the conversation with patients. And finally, there is oftentimes a failure to address the various diseases that are common in Black women, such as PCOS, or the presence of uterine fibroids, or blocked fallopian tubes, or obesity, all factors that may impact future fertility. And if they're not addressed early, our patients may actually present and then have conditions that are really devastating to their likelihood of being able to conceive. Patients also come with biases, and these have been addressed earlier, but in many instances, the concept of hyperfertility and or family history of large families and late conceptions in parents may give women the false sense of security regarding their own ability to have children. And so that may factor into why they present later for care. They may oftentimes feel shame and feel less or inadequate as a woman because of the infertility diagnosis. And then it is been well described that there is lack of support within the community. And this community can be family, it can be friends, it can be the church, which is oftentimes a institution that provides African Americans in particular a lot of emotional support. Around in the area of fertility, individuals find that they're often going through this journey alone. Religious belief systems are oftentimes complex. And when you look at many religions that are very fundamental, sometimes comments that may not be intentional, that either God will cure an illness or it's God's will that you have infertility, will cause patients to pause and as a consequence, delay their care. And then we've talked about the fact that there's a lot of lack of knowledge about female reproduction in general, the factors that impact outcome, fertility preservation, and the like. The distrust of the healthcare providers has been mentioned mainly because of historical factors. And so I think if we as providers come into an encounter recognizing patients may have some of these biases, we can address them head on and maybe impact the type of care and the comfort they feel in the consultation. So what are the things that we can do to provide a culturally informed care? One is use a patient-centered communication style that will allow us to develop mutual understanding. Part of that includes asking open-ended questions about the patient's life circumstances, and get into discussions in many instances about the values that they have and the preferences that they may have with regards to their fertility care and fertility journey. Avoid generalizing assumptions, which oftentimes reflect the biases we have when you're taking the patient's history and interacting with patients. And then probably most importantly is listen to the patient, listen to the things that she or he tells you, and then respect their cultural beliefs, even if they may be different from your own. In terms of developing treatment plans, it's really important to use shared decision-making when you develop this treatment plan. For some couples, a conservative approach, even trying treatments that you as a provider may not think are going to work very well, may be important to start the fertility journey so that they can then move through the journey at their own pace. And then recognize those factors that may be barriers to care and strategize on how you might overcome these barriers. I had an encounter this week with a patient who is losing her job and is going to have to go on state insurance. But what she didn't realize is that she now has the option to purchase insurance. And without counseling available to share those options, patients don't know. And then finally, understand what your own personal limitations are when you're addressing medical issues across cultures, so that if in fact you need to help patients by either having financial coordinators in your office or psychologists, address some of these issues, know when to engage them as well. One of the other aspects of providing patient-informed care, however, is diversification of the workforce. And when you look at the data, it is clear that when there are healthcare providers of color serving patients with the same cultural background, that these patients have better healthcare experiences and outcomes. When you look at some of the statistics from ACOG in 2017, only 11% of OBGYNs were African American. ASRM, we were able to look at the percentage of members of the ASRM that reported race and/or ethnicity. And since it's self-reported, only 131 members out of 8,000 members actually reported race and ethnicity. Our hope is that in the future, by requiring reporting as part of the registration, this statistic will improve and allow us to understand the demographic composition of our membership. From the standpoint of resident and fellowship training, the ACGME published statistics looking at how many OBGYN residents and how many REI fellows were African American. 8% of OBGYN residents, or 457 out of 5,677 OBGYN residents, were African American during this year, or 2019 to 2020, and 11 out of 167, or 6.5% of our REI fellows were African American. In addition, there's lack of diversity permeating our nursing community, our laboratory community, so they're embryologists, andrologists, and mental health providers. The focus in terms of increasing diversity in the workforce is therefore going to need to be intentional in order to change some of these statistics. And as part of the efforts of the Diversity and Equity and Inclusion Committee, it was suggested that pipeline programs be developed. These are mentorship or sponsorship or coaching programs to work with underrepresented minorities in medicine to try to increase the numbers of trainees that are recruited into our specialty, number one. And then moreover, looking even further back, trying to increase the knowledge of our subspecialty to individuals pursuing STEM careers to try to change these statistics. I'm going to close with just some general comments. If we can increase the overall representation of African Americans in the REI workforce, hopefully we will be able to elevate the conversation around issues that disproportionately affect African American patients and raise awareness among all providers within the practices. So this goes to this cross-cultural competency, if you will. There have been comments earlier about how the environment within which our patients are seeking care is really important, and making the practice environment more inclusive and reflective of all women and or patients that we see, especially women of color, is important. It will encourage trust among the patients who are seeking fertility care, and also, acknowledge the fact that the practices are working well to actively embrace cultural diversity. Additionally, a diverse workforce will encourage healthcare disparity-related research that will provide us with more information about outcomes in patients of color, and ultimately serve as a catalyst for positive change within our specialty. So thank you.
A common response from practice leaders and residency fellowship directors is that they select based on the best qualified candidates. We all hear that, right? Not based on color. What do you think of this comment, and how may this impact efforts to diversify the REI workforce?
Well, I think that institutions now are becoming a little bit more intentional about recognizing that the workforce needs to be diversified, and that the approach to interviewing or selecting residents and or fellows has to change so that you can incorporate other attributes of candidates that, are important in terms of, creating, your physician workforce. And that includes life experiences, various attributes that this individual may have had, competencies, as well as, kind of their academic and or scholarly activity. And so when you do that, you open up the, you're more intentional about looking at your applicant pool and interviewing candidates that bring other things to the table. Most of the candidates, quite honestly, that we interview, for instance, for fellowship, they're all qualified. So then you're looking, for other attributes that may match, kind of the goals of your institution, and et cetera. So it's more of a holistic approach than just focusing on board scores or, how many papers someone has written. We also have to acknowledge that not everybody has had the same experiences growing up. And so, the playing field is not always even. And that doesn't necessarily mean that, the end product, whether it be a resident or a fellow, that's our job, to mold and develop individuals into the competent positions that we want them to be.
Absolutely. There was an article talking about the F word, fit, right? That oftentimes we use it to exclude people. And we really have got to acknowledge our biases. One last burning question, which is actually for you. What would you say to an African-American OBGYN resident who is interested in REI, but is afraid of not successfully matching into fellowship?
First of all, I think that, identify a mentor early. If you don't have reproductive endocrinologists at your institution, there are reproductive endocrinologists throughout the country with whom you can contact and potentially work with. Whether that's doing an outside rotation or trying to do research, at another institution, but, be creative about how you try to build your resume so that you are competitive. And, that's the key. And so people, can meet you outside of your own institution. I know of a number of residents who have done just that and are very successful reproductive endocrinologists now practicing in the community. And so it definitely works.
I want to thank all of you for these fabulous presentation and discussion. And I want to thank our audience for participating. We have thoroughly enjoyed presenting this information to you and engaging you.